Thank you all for being here today. All right, the objectives, we're going to talk about adult sepsis and the things that we need to do in which to improve them. What we're trying to do with this presentation is to give you an outline of things that you need to be looking for your patient populations. I will be discussing the adult population because I don't do peds. No, I don't birth babies either, just for the record. All right, Surviving Sepsis campaign. They make it super simple. They have a 3-hour bundle and they have a 6-hour bundle, and they make it really, really easy. What they have said, so if you were listening to any of the CMS webinars that were going on in September, Dr. Livy, who is the sepsis doctor of the planet, has said that they will not be changing these with the next publication. So the 3- and 6-hour bundles will stand as they are with recommendations. So these will not change. You'll notice they're pretty straightforward. They want you to do lactate. They want you to get your cultures before you give an antibiotic. They want to make sure that you're using antibiotics that are broad spectrum. You'll notice that there is a very prescriptive way in which to give fluid, 30 mils per kg. You have to give that as your initial bolus. Then when you start to get into the 6 hours, that's when you begin to do your vasopressors. That's when you begin to do your reevaluations. And this is for your physicians or your nurse practitioners or your PAs to be able to do these follow-up assessments. Any of those will count. But they're very, very simple. And when you follow these, we see good outcomes. Now we're going to involve the government. So CMS has come out with their Sepsis 1 core measures. And they've taken that evidence, this huge body of evidence. I recently graduated from Texas Christian University with my doctorate in nursing. And my project was on sepsis. So this is near and dear to my heart. There is a ton of research out there on sepsis. And all of the best research, everything that is at the highest level for your evidence, so if you're trying to get, any of you are in school and you want to have a really good project to do, use sepsis because it has this great body of work in which to use. But the research that they do for this, and it is global research, it always hits the highest marks for the best research that's out there. And they are really looking at this across the board. So this has some really significant oomph behind it and how well this works. So CMS took that great body of knowledge and they have put it into their Sepsis 1 core measures. With the Sepsis core measures, they are using severe sepsis, and they are using septic shock. We know that this year that they have changed some of the definitions of sepsis, but CMS is not going to change this anytime soon. They're going to let these hold for now, and then they will continue to look at the evidence as it comes out to see if there's anything they need to change. So these are going to hold for a while. We know that they're always in discussion, CMS is, with what they change or not change. Not right now. This is good. So if you have severe sepsis, there are certain things that you have to do within 3 hours, and there are certain things you have to do within 6 hours. And if you have septic shock, there are certain things that you have to do within the 3 hours and certain things you have to do within the 6 hours. Now, one of the problems with that, sometimes you don't know which shock you have until after the patient has been dismissed and they've been coded. And if you did everything for severe shock and they coded out as septic shock, then you might not have hit your measure. So just kind of be aware that sometimes that's a little harder to hit than you might think. One of the things we wanted to do with the DFW Hospital Council on Sepsis is we wanted to give every facility a map for how to take care of sepsis and improve your outcomes. So that's what the rest of this is really going to be more about, is a map to help you in your institutions put together a program for sepsis that will help to improve your outcomes. That's what this is meant to do. So the first thing you have to do is you're going to have to triage. The recommendation is you screen every patient at their point of entry. So most of the patients that you see, adult patients that are coming in that are septic, 95% of them come in through the emergency department. So that's going to be your largest catchment zone. However, if you've got direct admits or you have some other entry into your system, you still need to be screening for sepsis. Sepsis, the initial screening question can be as simple as, do you have a potential or actual source of infection? Do you have a big open gaping wound? Do you feel like you have pneumonia? Do you have a potential source of infection? So you want to make sure that you're triaging these people. Notice that third bullet, self-reported information, especially fever. If the patient tells you, or for peds, the parent tells you that the patient has had a fever, even if it's self-reported, pay attention to that. It's one of your more important markers for this, but even if it's self-reported, you want to make sure you're doing it. And By the way, if your initial screen is negative, no, I don't have any potential source of infection. I am here because I have gout. Still, you're going to need to rescreen. We have often found that if we don't rescreen, we're going to miss you before you go home, and then you're going to come back. How many of you all know the Rory Stanton story from New York? Some of you will raise your hands. That was a young man, 12-year-old, came into the ER. He'd had a cut on his arm. I'm sure they're going to go into this with pediatrics. I'm not going to steal too much of their thunder. They did not identify sepsis. He came back a couple of days later and died. So you need to make sure that you are rescreening for sepsis and that we're trying to catch them. Now, your rescreening can be a couple of different ways, because I am an informatics nurse. I love the electronic health record. It is my friend. So you can either do this as time. So I had a negative rescreen. Now I'm going to have a set time that I'm redoing it. So I'm going to rescreen it an hour, and I'm going to rescreen before I send them home, especially if they're in the ER. Or I might have something that is set up within my electronic health record that is a trigger to let me know I need to rescreen. It might trigger you at the hour. Here's your hour, you need to go do this. Or it might trigger you because your vital signs and your other predictive analytic tools, which we'll be getting into, tell you, hey, you might want to go look at this patient, something's wrong. When you assess and reassess, make sure you're doing your vitals. Vital signs are vital. There's a reason they're called that. And you want to make sure that you're getting a good temperature. Literature shows that getting an axillary temperature is not the best method of getting a temperature. So if you really think you have a septic patient, you probably want to get a route of temperature that's something other than the axilla. Lab values. You noticed on the core measures and when we were going through the Surviving Sepsis campaign, they like lactate. And they love cultures, and we really want to get a white count. So there are certain things that they're really tagging on that you need to make sure that you're getting. Then, how's your patient's level of consciousness? What's going on with that? And then predictive analytics. I love predictive analytics because if you think that the electronic health record is there for you to just put information in and it should never help you again, we need to have a chat. Because the electronic health record is really there to support the care, and the things that are being put in should be then giving you things back in which to help you improve the care of your patient. And if your electronic health record isn't doing that, then it's not doing you justice. So use the predictive analytic tools that you have within your electronic health records. Every single electronic health record has the capability to do this. You'll want to use those. We're going to go more into the modified early warning score and the SIR score, systemic inflammatory response. We're going to go through those a little bit more in depth here shortly, so hang on with that one. Then you want to use other predictive scores. There are several really good evidence-based scores besides the MUSE and the SIRS that will help you pinpoint sepsis. Then, last but not least, clinical judgment. If in your gut you know something ain't right with that patient, go with your gut. Even if all of the rest of this is, hey, I think this is really normal and we're all good, but something doesn't quite look right, go with this something doesn't quite look right. So you can have every predictive analytic tool on the planet, you can have every vital sign, and if you still think something is wrong, go with your clinical judgment. Do another screen. Send up the red flag. Look. Dig deeper. Notifications of your care team. Once you have identified a septic or potentially septic patient, it's time to call in the sheriff. You're going to need help. As Chris was talking about earlier, sepsis is a deadly condition, and most people, unfortunately, really don't see it as an emergency. It is an emergency. Just as if you were having a heart attack or having a stroke, you need to be taking care of sepsis as if this person is going to die in about 3 hours, because that's pretty much what's going to happen if you don't. So make sure that your provider is notified. If you are fortunate enough to have physicians readily available, get hold of your physician. Some of the smaller institutions or someone that's out in the rural community, they might be using a nurse practitioner or a PA. That's perfectly fine. If you're very lucky, you can have a code sepsis team. So this is a team within your institution that is trained in sepsis, and when they have a septic patient, they can respond. How many of y'all have stroke teams? How many of y'all have sepsis teams? Good. You want to try to develop that sepsis team, that expertise. If you don't happen to have a code sepsis team, hopefully you have a rapid response team. Call the rapid response team. This is something that needs to be looked at. You need those extra resources to take care of this patient. Then make sure that you're doing this in a timely manner. This cannot wait. Wait as long on sepsis as you would when they collapse in front of you with a heart attack. That's about the same amount of time that you need to be waiting for this. You need to be getting in contact with your care providers. And even though I am the poster child for the electronic health record, nothing, repeat, nothing takes the place of good verbal communication between providers. If you think your patient is septic, you need to be getting on the phone or going face-to-face with your physician to get this taken care of. Because you can notify in the electronic health record all day. That's great. It's wonderful. You need to have the conversation. Transfer of care. I really wanted to try to get a slide of the U.S. Relay team dropping the baton again for doing this. But transfer of care, and that doesn't matter if it's an internal transfer of care between your ER and your ICU, or if this is an external transfer of care between one hospital to another. You have got to have a good handoff of these patients to make sure everybody knows what's going on. So if you're going from the emergency room, hopefully your septic or potentially septic patient is going to the ICU. It has been shown that outcomes improve if they go to the intensive care unit instead of to a floor. But you want to make sure that you have a clear handoff. So if I started my 3-hour bundle in the ER and I've started and I've gotten my lactate and I've done my cultures and I've started the first antibiotic, but I haven't quite started that fluid yet, when I hand off to the ICU nurse needs to know, I've done this, I've done that, I have not started my fluids yet, they need to be started. You need to have a very good, clear handoff of what has been done, what has been ordered, and what needs to be done and taken care of. That should be nursing 101, one would hope. It also needs to happen in your external transfers of care. So if you are going from a facility where you might not have an ICU available or you don't have the resources available to care for a very sick patient, they might be being transferred. Same thing applies here. If I'm going from hospital A to hospital B, I need to make sure that I let them know, here's what we have done, here's what we have started, and here's what has not been done that you need to take care of when they hit your door. The other thing, if you're sending somebody that's having a stroke or heart attack, do you stop treatment in the ambulance? No, you don't. You continue treatment in the ambulance. Same thing with sepsis. You're not going to stop the fluid, you're not going to stop the antibiotic, you're not going to stop any of those things for any transfer, whether from the ER to the ICU or from hospital to hospital. That care needs to take place while they're in transfer, because once again, this is a very quick and deadly condition. Early goal-directed therapy. You heard Chris talking about this earlier. This is what we want to do for our septic patients. When you're setting this up in your facility, make sure that your sepsis order sets for your clinicians are concise and clear and as short as they can possibly be. This is not the time to add in 62 different things, and here's my one for VTE, and here's my one for this other thing that we're doing, and I really wanted to get this other measure in. No, it's for sepsis. So you want to make sure that you get the right labs, that they're easy to order from the set, that you have the right antibiotics, have broad spectrum first, and then you want to narrow that as rapidly as you can. As soon as you know what the infectious agent is, you want to bring that down. Good antibiotic stewardship, right? Yes, we like antibiotic stewardship, it's happy. You also want to have those antibiotics readily available. If at all possible, if you can work with your pharmacy to make sure that you have those broad spectrums available in your ER so there's no delay in waiting for them to come up from the pharmacy to start a broad spectrum, the better off you're going to be. The less delay that you can do and build into your system to have these available, the faster your treatment will be, the better your outcomes will be. Fluid, we keep hitting the fluid, imagine that. That 30 mils per kg is the initial bolus. You have to hit that mark for the initial bolus. That doesn't mean that's the only fluid you're giving. That means that for that first bolus, it has to be the 30 mils per kg. And if you do the math, that's over 2 liters of a bolus for the first thing that you're giving. And you're going to give all of it, and it's not kind of one of those wait. Any of the subsequent boluses for that, those can be your 1 liter, that can be your, whatever it is, but that first one has got to be 30 mils per kg. And it's a bolus. Give it. Drown them. It's okay. On the antibiotics, CMS gives us a table that is done by area. So if you think that they have a hot abdomen and they have a gut, here are the antibiotics you need to use. If you think that it's pneumonia, here are the antibiotics you need to use. They have it for you in a table called 5.1. It's easy to find. I'm not going to put a slide up of it, and you're welcome. Then we also have vasopressors. Your norepi is the gold standard. If you are giving all of your fluid and they are still hypotensive, you're going to want to start them on norepi. All right, other goal-directed therapy. How many surgeons do I have in the room? I should have at least one hand go up. Thank you. You want to make sure that you're doing source control. So if they come in with a hot abdomen, they need to go to the OR. If they come in and they have a large infected wound, they need to have it drained. You need to do source control for whatever is causing them to be septic, right? So we have this lovely order set. We have all these great things that we're doing. We cannot forget that we have to be treating that part of it that is causing the sepsis. So if you know what it is or you have a good idea, then you need to be taking care of that. Then reassessment. CMS is very prescriptive in their reassessment, and they give you two ways in which to do this. You can either do it by a set of vital signs, and it's not a vital sign, it is this list of vital signs, and it has to be documented by the provider. It can be taken by the nurse, it has to be documented by the provider. So they're not really expecting the physician to do a blood pressure, but they are expecting the physician to document the blood pressure. Then you want to make sure that you've got your other ones available. So you can do 2 of 4 tests. You can do a CVP, you can do an echo, you can do venous gas, or you can do what we all love, is like a passive leg raise. Who knew what a passive leg raise was before CMS came out with that? How many of you all knew what a fluid challenge was? Thank you, Dr. Velasco, for the one hand that went up. So everybody else knows what a fluid challenge is. That's really what we're looking for. It's a fluid challenge. Then determining severe sepsis versus septic shock. Like I said, be very careful with this one because sometimes you think you're treating severe sepsis, but they get coded out as septic shock. And if they get coded out as septic shock and you didn't treat for it, ding, you didn't meet your measure. Care coordination. We have got to talk to each other. Keep everybody updated. Find a way to do that. If you have a good way within your electronic health record to do that, otherwise, you are always going back and making sure this is part of your report, this is part of your handoff, that you have some tool that is available to you that gives you a good, clear handoff for communication among your care team. Don't delay. I think you're hearing that over and over from us today, is do not delay the care of this patient. This is not something you sit on and wait, because it will kill you. I love one of the videos, and there are a lot of really cool videos on YouTube for sepsis, and one of them had a set of triplets, and they said, okay, this triplet just had a heart attack. What's the chance that this one's going to die? And it was less than 20% chance they were going to die. And this triplet had a stroke. What's the percentage of chance that this triplet's going to die from stroke? And it was less than 10%. And then the third one is this triplet has sepsis. What's the percentage that this one's going to die? And it's greater than 50%. So if you're looking for something that's going to kill them, it's sepsis.